Yeah, doctors, is my screen visible and am I audible? Am I audible and is the screen visible?
Yes, ma'am.
Okay, cool. So let's start off. Okay. So remember, there are different techniques for evaluation of the validity of a diagnostic test. So you need to know some definitions first. So what is a diagnostic test? A diagnostic test is something that helps us to differentiate between a diseased and a non-diseased person. Okay. And what is a screening test? Screening test is basically to pick up diseased people amongst a healthy population. That is, it is basically an incidental finding. It's used to identify unrecognized diseases. Okay, so basically screening is to identify unrecognized diseases or to pick up the disease in a normal healthy population. But a diagnostic test, it is used to differentiate or pick up diseased from like it's used to differentiate between a diseased and a non-diseased person who might have sometimes similar symptoms. I hope it's clear now. So basically, diagnostic testing is done whenever a person has symptoms, but screening is done even in healthy individuals, that is in normal individuals. Clear? Any doubts?
No, ma'am.
Okay. And next, another important terminology is the gold standard test, which is nothing but the definitive test or the most appropriate test. Now, this determines whether the disease is truly present or not. It basically has a higher chance of picking up the true positives, that is, those who have the disease. Next, let's move on to the exam favorites, which is sensitivity, specificity, false positive, and false negative. Now, sensitivity is basically the proportion of true positives, and specificity is the proportion of true negatives. Now, who are true positives? True positives are those who actually have the disease. And if the test has a higher sensitivity, means it actually has a higher chance of picking up picking up patients who actually have the disease. What do you mean by specificity? It picks up true negatives. That is, it helps in picking up normal individuals. That is, individuals who actually do not have the disease. Now, false positive rate and false negative rate. False positive rate is the likelihood of a positive test result in a patient who is actually normal, who's free of the disease. And false negative rate is the likelihood of a negative test in a patient who actually has the disease. Okay, in our exam, the last four are actually very important. So is this clear?
Yes, ma'am.
Okay. Next, moving on to the truth table. This is something which you'll need to memorize, not as ABCD, but as true positive, false negative, and true negative. So always remember the row. The top row will always have the will always have disease present and disease absent. And remember, the column will always have test positive and test negative. So like we know, true positive is when the test is actually positive in a diseased person. And again, false positive is when in a normal individual, the test is positive. Now, true negative is basically, this is what we have to look at. True negative is when both the test is also negative and the disease is negative as well. But false negative is actually the test is negative in a diseased person. The definitions which generally are these are the phrases which will actually come in the exam as options with respect to definition. So you will have to memorize these phrases. So true positive is sick people who are correctly identified as sick. False positive are healthy people who are incorrectly identified as sick. Then true negative is healthy people who are correctly identified as healthy. And false negative is basically sick people who are incorrectly identified as healthy. So these definitions you need to memorize because these are the phrases that will come as options in your question with respect to definitions. There's a mnemonic to remember sensitivity and specificity. Remember, whenever they talk about sensitivity, you look at false negatives. So in other words, it is nothing but true positive. Specificity, you're looking at false positive. So how I remember is it as because sensitivity has N, so it helps in detecting true positive, and because specificity has P, it helps in detecting true negatives. Then another important thing which they ask you in your exam, again, which you need to memorize, is about high sensitivity and a high specificity. So sorry about that. So remember, what do you mean by high sensitivity? High sensitivity means it is high true positives or few false negatives. Okay. Then low sensitivity means, again, it's just the reverse. It's going to be many or more false negatives, which is nothing but few true positives. So you can remember any one. I would suggest you to remember high sensitivity. So high sensitivity means high true positive or few false negative. And on the other hand, high specificity means few false positives or high true negatives. Okay. So the other two become obvious then. Even this has been asked many times. So please memorize it. Simple calculations. Just by filling the values in the table correctly, you can come to the right answer. Okay, so please memorize the truth table in this format itself. So sensitivity is nothing but, again, you'll have to remember this formula, which is true positive by true positive plus false negative. Specificity is true negative by true negative plus false positive. False negative rate is, again, false negative by true positive and false negative. And false positive rate is, again, false positives by true negative and false positive. Again, you'll have to memorize this, like I said, because you're going to get simple calculations. So memorize the truth table, and then it'll be easier for you to memorize these formula. Clear? Any doubts so far? Come on. Any doubts? Am I
No.
audible?
Yes,
Okay,
ma'am.
thank you. Cool. Okay, so again, this is just a repetition of the truth table and the different formulae which you need to remember. Why I put up this is you again have to remember two additional formulae apart from these four. That is the positive predictive value and the negative predictive value, and also accuracy. Okay, so for positive predictive value is, again, true positive by true positive plus false positive. Okay, you'll have to watch out. This is almost similar to sensitivity, but you need to look at the denominator. In the denominator for sensitivity, you're going to have false negative here. But in the denominator for positive predictive value, you're going to have false positive. So the easier way is always positive predictive value will all have positives in the numerator and the denominator. That is true positive by true positive plus false positive. So that's the easiest way to remember. Now, negative predictive value, again, it'll always be full of negatives, both in the numerator and the denominator. So it'll be true negative by true negative plus false negative. Now, sometimes they just don't stick to the formula. They will move on to definition, the use, as well as the proportionality, which you need to remember. Now, what is the definition of false predictive value? False predictive value is the percentage chance that a positive test is true positive. Okay. In other words, it is the percentage chance that a patient with a positive result will actually have the disease. Sorry about this. And the most important use is to determine how to it helps us to detect whether the patient who's actually, it helps us to determine whether the patient actually, the chances of the patient actually having the disease. That is, a patient who tests positive, whether he actually has the disease or not, it helps us in determining the chances of that happening. So that thereby it helps in formulating the next step in management. Now, what they ask you about is this thing. Remember, whenever the whenever the positive predictor value is high, the prevalence is high. Okay, so a high positive predictor value is associated with a high prevalence. Now, moving on to negative predictive value. So negative predictor value is the percentage chance that a negative test is that the negative test result is a true negative. That is the chances of detecting whether a patient with a negative result is actually normal or disease-free. Okay, and the important thing they ask about negative predictive value is again the relationship to prevalence. Remember, a low negative predictive value is associated with high prevalence. So in other words, remember always high prevalence of a disease is associated with a high positive predictive value and a low negative predictive value. Is it clear? Is it clear so far?
Yes,
Can you
ma'am.
please repeat it?
So which one? Is it the last part, or you want me to start off with the positive predictive value?
The last part.
Okay, so remember, to put it simple, a high prevalence, a high disease prevalence is associated with a high positive predictive value and a low negative predictive value. Obviously, if positive is high, the negative will be low, isn't it? So this is what they ask you in the exam more commonly. Many of them go wrong because of this confusion. So that's the reason why I put up this table, so that you can just memorize the table. I know it is tricky to memorize, but you don't have an option. These are questions where, you can't miss out. They are very easy to answer, provided you keep memorizing them. That is, frequent revision is needed. So is it clear now, the last part?
Yes, ma'am.
Okay. Now, the last important formula with respect to this slide is accuracy. Now, how do you determine the accuracy of a test? Again, remember this formula. It is true positive plus true negative by, again, true false positive and true positive plus false positive plus true negative plus false negative. So all the four come in the denominator. Okay. So I'm quite sure you all can nail the calculations if you remember the truth table correctly. Now, so we have discussed about a predictive value, that's positive and negative predictive value. Let's talk about likelihood ratio, because even this has been asked quite frequently. Sorry. So what is likelihood ratio? It compares the proportion of patients with or without disease with respect to their test results. Okay. How is this different from predictive value? Predictive value is basically the probability of a test result that reflects whether the patient is actually truly diseased or not. But likelihood ratio is taking the proportion. So basically it is a ratio, in other words. But predictive value is the chance, it is the percentage, it is a probability. Now, positive likelihood ratio is nothing but proportion of affected individuals who test positive divided by proportion of healthy individuals who test positive. So in other words, it is, can you tell me what's the numerator? What is proportion of affected individuals who test positive? They're nothing but true positives, right? And the proportion of healthy individuals who test positive is nothing but false positive, correct?
Yes.
Okay. Now, what is negative likelihood ratio? Now, negative likelihood ratio is proportion of affected individuals who test negative. So what is the proportion of affected individuals who test negative? They are nothing but false negative. Okay. So divided by proportion of healthy individuals who test negative. So what are healthy individuals who test negative? They are true negatives, isn't it? I'm just trying to rephrase this with respect to true positive and false positive, the truth table values, so that you can apply this when solving the problem. Sometimes it may not be this direct. They might just give you true positive, false positive, or they may word it like that. So it is better to remember it as true positive by false positive and false negative by true negative. Clear?
Yes, ma'am.
Okay. Now, again, another important thing which they ask you about is calculation of odds ratio and interpretation of odds ratio. So what is odds ratio? Odds ratio is an association which quantifies the relationship between an exposure and health outcome from a comparative study. So basically you're comparing the exposure and the outcome. You're taking the ratio between the two. So where do you calculate odds ratio? You calculate odds ratio in a case control study. Okay, it is only calculated in a case control study. Now, what is odds ratio? Odds ratio is cases amongst exposed divided. It's basically case by control. Okay, so you'll have to remember this ratio, that is, it is AD by BC, and the truth table as well. Then another important thing, like I said, is interpretation of odds ratio. Now remember, whenever the odds ratio is 1, it means that what is case control study? You're seeing whether the exposure to a particular risk factor is actually okay, I'll talk about that with respect to the flow chart. I will not talk about the definition of case control right now. Okay, let's talk about only odds ratio here. So remember, when the odds ratio is 1, it means that the cases amongst exposed is the same as the cases amongst non-exposed. In other words, the risk factor which is being studied is not a relevant one. Okay, because the disease is occurring in the same frequency amongst both the cases and the controls. That is the exposed group and the non-exposed group. So it is not a significant risk factor. In other words, the exposure is not associated with the disease. Is it clear? Any doubts? If you want me to repeat, I can repeat.
Can you please repeat?
Okay, see, if the odds ratio is 1, it means that the numerator is equal to the denominator. That means the disease in the case group is the same as the disease incidence in the control group. So in a case control study, you're studying the relationship between the exposure to a risk factor and the association with a particular disease. Okay, that's the main heart of a case control study. So in a case control study, whenever you calculate the odds ratio, whenever it's 1, it means the numerator is equal to the denominator. In other words, the disease incidence is the same irrespective of exposure to the risk factor. So in other words, there is no relationship between the risk factor and the disease because it's occurring in the same percentage in both the case group as well as the control group. And like you all know, the case group is basically where you're exposing the subjects to a particular risk factor, and the control group is you're not exposing them to the risk factor. That is the other placebo group in the other hand, in other words. Is it clear now?
Yes, ma'am.
Okay. Now, when the odds ratio is more than 1, we know whenever a ratio is more than 1, the numerator is greater than the denominator. That means the odds of exposure amongst cases or the disease incidence amongst cases is much higher than the disease incidence amongst controls. So, in other words, because the disease is definitely higher in the case group, there is a strong relationship between the exposure or the risk factor and the disease. Is it clear?
Yes, ma'am.
Come on, you guys. Yeah, if you just tell me yes or no, I can repeat it quickly or proceed. Then if the odds ratio is less than 1, it means that the numerator is lesser than the denominator. That is, the exposure to a particular risk factor, or you can say the incidence of disease amongst the exposed individuals is lesser than the disease incidence in the control group. In other words, the exposure or the risk factor is protective. That's the reason why it's resulting in a lower incidence of the disease. Is that clear? Any doubt? Any doubts?
No, ma'am.
Okay. Now, another thing the test use about accuracy and precision. So with respect to the formula and calculation, only accuracy will be asked. But with respect to definition and identification of whether a particular test has a high accuracy or a high precision, you need to know it. So accuracy is with respect to definition and calculation, but precision, only the definition is important. So what is accuracy? Accuracy is how well a measurement agrees with the accepted value. Okay, that is you're checking the relation, what do you say? How do you put it? For example, if there is an accepted value, you're seeing how close the measurement is with respect to the accepted value. And on the other hand, for precision, you need a series of measurements. So you're seeing how well a series of measurements agree with each other. So in other words, accuracy, you're testing only one particular measurement and you're seeing how close it is to the accepted value or the accepted range. But in precision, you're just checking whether a series of measurements are close to each other or they are apart from each other. You're not checking whether they are close to it doesn't matter whether they are close to or away from the accepted range. That is, the relationship with the accepted range is not taken into consideration, but you're taking into consideration how well they are, accepted with respect to each other. Is that clear?
Yes, ma'am.
Okay. Now let's look at this target. And like we all know, this is the bullseye. And generally, we all know the bullseye is the accepted value. Like we see in this, in the first picture, all the values are close to the target, to the bullseye. And also, with respect to each other, all the values are clustered around the bullseye. So because each value is closer to the accepted value or the bullseye, the accuracy is high with respect to each value. And because all the values are clustered, the precision is high. But if you look at the second picture here, they are all clustered together. So the precision will be high, but they are all far from the bullseye, which is the accepted value. So the accuracy will be low. Then if you go to the third picture, here only one value is coinciding with the accepted value. The others are quite close. They are not very far. So the accuracy with respect to each measurement is high. But all the values are, they're not close to each other. They're slightly away from each other. You can say equidistant from each other, but they're not close to each other. So that's the reason why the precision is low. And the last picture, if you see, the distance of only one value is, you can say, a bit close to the target value. But overall, when you take all the values into consideration, each of them are quite away from the bullseye, which is the accepted value. So that's the reason why the accuracy is low. And if you look at all the series, all the values as a whole, even they are quite separated from each other. So that's the reason the precision is also low. And in our exam, they generally give you the picture and they ask you to identify, and this is the one which they give you. So that's the reason why I've given you all the 4 scenarios so that you can just memorize them and mark the answer. You don't have to apply any logic and waste time. Okay, the answer got revealed. So is it clear?
Yes, ma'am.
Yes, ma'am.
Okay. Now let's see how well you again the formula for accuracy, I've discussed it in the previous slide, so I'm not touching on that now. So now let's see how well you've understood. Now tell me, what is the first picture with respect to accuracy and precision? Be quick, come on.
Low
So what's the
accuracy,
accuracy?
high precision.
Accuracy,
Yes, very good. What's the second picture?
High
high
accuracy,
accuracy, high precision.
Very good. And what's the third picture?
Low accuracy,
Low accuracy, low precision.
Very good. So you guys have got this concept now. You'll nail it if it comes in the exam, right?
Yes.
Okay. Another tricky one which comes in the exam is this: numbers needed to treat and numbers needed to harm. Again, the definition for both are important, but the calculation for numbers needed to treat is what could be asked. Okay. So what is this numbers needed to harm and what is the numbers needed to treat? So numbers needed to harm is the number of subjects if given a harmful exposure, which is generally a risk factor, would cause the one case of a disease. So you're checking the chances of a particular risk factor resulting in one disease in a one case of a disease in a population. That is the number of times the number of subjects who need to be exposed to the risk factor to at least get one patient as a disease positive patient. Is that clear? These are different ways in which this can be framed. You have to memorize it. There's no option. Any doubts? Do you want me to repeat the definition again?
Mm.
Okay. And there's another way of putting this, the same thing. So remember, the one which generally comes in the exam is the second one, and it is the number of patients who should receive a treatment for one of them to experience an adverse effect. This is one way in which it is framed, and this has come in the exam. Okay. Or the other one is the number of patients who need to be exposed to a risk factor for at least one of them to be disease positive. So these are the two different ways in which, they can ask you the definition in the exam. So with respect to disease and with respect to adverse effect, both have come. But adverse effect has been asked more frequently, but it's better you know. Clear?
Yes, ma'am.
Okay. They have not asked about the formula or the calculation with respect to the numbers needed to harm. So because the formula is a bit tricky. So that's the reason why I'm not going to discuss it. But I think, yeah, it's not been asked. So you can just forget about the formula for numbers needed to harm. Numbers needed to treat. Now the formula for numbers needed to treat is basically 1 divided by the absolute risk reduction. Okay. So what is the definition? Now it is the number of subjects if given a particular treatment or protective exposure that's needed to get at least one case of the disease. Okay. The other way of framing the same definition would be the number of patients who would have to receive the treatment to at least, for at least one of them to get benefited. Sorry, not to get the disease, it is to get benefited. You're basically checking the benefit because it is involving treatment. So to repeat myself, it is the number of subjects if given a particular treatment or a protective exposure would prevent one case of a disease, or it is the number of patients who would receive the treatment for at least one of them to be benefited without getting the disease. So is it clear?
Yes, ma'am.
So always so number needed to treat, basically it helps, and it is needed to at least get one patient disease free, and number needed to harm, it is the number needed to at least get one patient with the disease. So harm is getting the disease and treat is disease free. So that's the way you can remember. Now another way to calculate this numbers needed to treat is, it is 100 divided by the absolute risk reduction expressed in percentage. So it's going to, again, if you do your mathematics, it's going to come back to 1 divided by absolute risk reduction. Okay. Now, generally absolute risk reduction will be mentioned. They will give you the answer in the question, or sometimes if they really want to test you, they will give you certain they will give you a scenario wherein you'll have to calculate the absolute risk reduction. And this is the formula you use for absolute risk reduction. Where's my marker? Okay. So remember, absolute risk reduction, it is nothing but ARC minus ART. Now, what is ARC and what is ART? ARC is the absolute risk of events in the control group, and ART is the absolute risk of events in the treatment group. Okay, so this is the formula for ARC, and this is the formula for ART, for which, again, the truth table will always remain the same. Sorry. Remember, always disease will be in the top row, and in the column, you're either going to have treatment or risk factor or exposure. Okay. So always the row remains constant for all the truth tables. So again, this is something you will have to memorize. So if instead of going on to absolute risk reduction, if they give you a truth table and ask you to calculate the relative risk reduction, then the formula will be absolute risk reduction minus ART by, again, absolute risk reduction. I mean, in the control group. Sorry, it's ARC, absolute risk in the control group minus absolute risk in the treatment group divided by ARC. So you got to remember both the formula. Relative risk reduction hasn't been asked, but it is, again, there is a likelihood of it to be asked if they want to complicate your, your question. So is it clear about absolute risk reduction, ARR calculation? Any doubts? Come on, if you have any doubt, you can ask me. Otherwise, I shall proceed. Shall I proceed?
Yes, ma'am.
Okay.
Yes, ma'am.
Now, some other important topics are this relative risk, attributable risk, then population attributable risk. Okay. The others, the population attributable fraction is not being asked and it's not important. Odds ratio I have discussed. Okay. So let's talk about relative risk. Now, what is relative risk? So relative risk is nothing but it is used to compare the risk in two different groups of people. So it's nothing but the ratio of the risk in two different groups. So what is the formula for relative risk? It is incidence and exposed by incidence and unexposed. In other words, it is how many times more likely are the exposed individuals to become diseased relative or in comparison to the unexposed. Okay. So sometimes they wouldn't give incidence in exposed and unexposed, and they will just give you the truth table, which is when you'll have to use this formula and calculate the relative risk. Sorry. Another important point. So remember, if the relative risk, again, another important point is the interpretation. So if the relative risk is less than 1, it means the event or the disease is less likely to occur in the experimental group, or it is more likely to occur in the diseased group. Okay. Then if the relative risk is more than 1, it means the event is more likely to occur in the experimental group. So remember, if relative risk is less than 1, the event is less likely to occur in the experimental group because the numerator is less. It's nothing but experimental group is nothing but the exposed group. And if the relative risk is more than 1, it means the event is more likely to occur in the experimental group or the exposed group, because again, the numerator is more. Clear?
Yes, ma'am.
Okay. Now, attributable risk. Now, remember, attributable risk, it is not a ratio, but it is actually a difference. It is what is the incidence of disease that is attributable to exposure. So it is nothing but incidence in exposed minus incidence in unexposed. And again, this is the formula you need to know about attributable risk. In other words, in relative risk, you're only comparing, you're not taking other compounding factors into account. But in attributable risk, you are taking other compounding factors into account. If you all remember the same thing that I discussed in OBG with respect to the contraceptive efficacy of IUDs. There I've spoken about relative risk and attributable risk. Do you guys remember that? No? Okay, you need to go back and revise. So generally attributable risk and absolute risk are almost the same. Okay. So they are used interchangeably sometimes, but in our question, they generally ask you about attributable risk. That's what is being asked. That's what will be asked. Just remember relative risk and attributable risk. Okay. Clear so far?
Yes, ma'am.
Okay. Now let's move on to another plab favorite, which is the epidemiological studies. Now, again, this classification of epidemiological studies into observational studies and interventional studies. Observational are non-experimental and interventional are always experimental. And in experimental or interventional, you're going to have RCT, that's randomized controlled trial, which is nothing but a clinical trial, or non-randomized experimental trial, which is nothing but a field trial or a community trial. And they generally ask you about RCT in the exam. I will explain to you as to how you get to it. Now, observational studies, they are non-experimental. Now, these could be population-based or individual-based. And it is the individual-based that they generally ask you in the exam. Individual-based ones can be descriptive or analytical. And the descriptive one are case reports or case series. In case report, you're basically reporting an unusual case. And in case series, you're reporting a series of cases which are similar to each other and are quite unusual. Then in analytical studies, you either have cross-sectional, case control, or cohort. Remember, cross-sectional study is a prevalence study. Case control study is a case reference study. And cohort study is also called a follow-up study. Sometimes the synonyms can be used instead of using the conventional terms. So you need to know both. And in population-based studies, you have health survey and ecological study. That's not been asked. Okay, so let's look at the strength of evidence. Remember, the highest strength of evidence is basically given by an interventional study or by a clinical trial. So what is happening in a clinical trial or an RCT is basically it is an investigator who is generally blinded, and even the subjects are blinded. Okay, that is, they don't know anything about each other, no details are shared. And then the investigator will randomly allot the subjects into different groups, and that is basically interventional and non-interventional group. And then the study is conducted. Okay. Now let's talk about the other studies. Like I said, case report, you're reporting a single case. And in case series, you're reporting a series of similar cases. Okay, which is unusual. Then remember cross-sectional study. Cross-sectional study is a prevalence study. Here you're taking a single sample from a larger population and you're studying. So this basically there is no comparison that is done here. So that's the reason it's also called prevalence study, because it helps in determining the prevalence of a particular disease. Okay. So then you also have cross-sectional analytical study. This is another type of prevalence study. So in this sort of prevalence study, that is the cross-sectional analytical variety, the population is divided into, here what happens is a single sample is taken from the population, and this sample is divided into generally two groups. But the one that comes in our exam is basically the single sample wherein you're studying the prevalence. That's what they ask you in the exam. But it's better you know that there are two varieties of it. You have the descriptive one and the analytical one. And in descriptive one, you don't divide, and in analytical one, you'll divide the sample. Then in case control study, of course, you're dividing the patients into two groups, that is the cases and controls, and you're trying to study and the cases are basically those individuals who are exposed to a risk factor or who are diseased, and controls are basically those who are not exposed to the risk factor, those are not diseased. Okay, that's the word which is used interchangeably. And then you're comparing the risk factors, but in cohort again, you're not comparing the risk factor, but you're comparing the outcomes. Okay, so cohort is basically a forward study, whereas case control study is a backward study. But in cohort, again, you have two types. I have put that in a flow chart so that, yeah, this is the one which I want you all to actually remember. Okay, before going to that, let's talk about the definitions of each. You will have to know a bit more. Now remember, descriptive study, like I said, you'll have to remember the disease. Basically, in this type of study, the disease distribution in a particular community is studied with respect to the time, place, person, and also associated risk factors, and even ethnicity as well. Okay, so that's easy. That generally doesn't come in our exam because it's quite easy. Now, case control. Now, in case control, you're dividing the study group population into two groups, basically cases and controls. Cases are those who have the disease and controls are those who are disease-free. After dividing the study sample into two groups, that's cases and controls, depending on whether they have the disease or not, then the prevalence of a particular risk factor is studied in each of these groups. Okay, after the prevalence is studied, or after the prevalence in each of the risk factor in each of the group is determined, then you compare the prevalence between the two groups. Okay, that's the reason why odds ratio comes into picture. So you're trying to associate whether the risk factor or the exposure is actually causing the disease, or whether it is protective with respect to the disease, or whether it has no connection at all, depending upon the odds ratio value. Is it clear? So in other words, generally, case control study is a retrospective study. That is, you already know the patient has the disease, or whether the patient doesn't have the disease, and you're going back to see whether the risk factors actually cause the disease or not. So is it clear, or you have any doubts? Or you want me to repeat anything? Come on, I at least want some response from the other side.
Yes, ma'am.
Thank you. Now moving on to cohort study. Now cohort study it's generally a prospective study, but you even have a retrospective one. So let's see what a cohort is. Now what is a cohort? Now cohort is a small group, generally a small group of people who have a similar feature. And the similar feature could either be age, or it could either be gender, or it could either be ethnicity, or something. It could be anything. So basically they will have a similar feature in common. So then after after determining the cohort, one group of people is generally exposed to the risk factor, and the other group of people is similar to the exposure cohort, is not exposed to the risk factor. So those who are exposed to the risk factor is termed as an exposure cohort, because being exposed to the risk factor is something common. And the other group, which is similar to the exposure cohort, similar in terms of age, ethnicity, etc. But the only difference is it is not exposed, there is no exposure to the risk factor. So it's called the control group or the control cohort. So is it clear so far about exposure cohort or the case cohort and the control cohort or the non-exposure cohort?
Ma'am,
Any
you'll have to
doubts?
read it again, probably to.
Definitely, yeah. At least I would have read this in my PSM maybe 15 years back. And I would have read it for my NEET at least maybe some 20 times, because in NEET it's more tricky. Like you all know the questions. Plab is a bit simple. And again, to coach in plab, because I have reached the level of vitreoretinal surgery and I would have completely forgotten about PSM. I would have read this more than 50 times to actually memorize and teach confidently. Okay,
Yes.
so you can imagine how many revisions you need to give so that it goes to the subcortical level, and you'll just be able to answer the question. One
Yes.
reading won't suffice. Be prepared. You'll have to read this daily for at least 2 weeks. And then maybe you can think of revision. Okay, because
Yes, ma'am.
biostats questions and such things, they are, it is like you can get confused with medicine questions or with surgery questions because they are diagnostic. Okay, but these are not diagnostic questions which will cause a dilemma. These are questions, it's like all or none, it's like mathematics. You need to know
Actual,
them, the
yeah.
theorems. You remember? Yeah, so theorems, you have to remember them the way they are. So the same thing goes here, okay? Remember, just try to revise this day, try to memorize this daily for the next 2 weeks and then revise. That will help.
Okay, ma'am.
Okay. Yeah. So you have an exposure cohort and a control cohort based on whether the study population or the study group is being exposed to the risk factor. Remember, the groups are actually similar with respect to all factors. The only difference is one is exposed to the risk factor and the other is not exposed to the risk factor. Okay.
Yes.
Now, after this exposure is being done, remember both the groups are regularly followed up for a definitive period. And generally this definitive period is not for months, it goes on for years, like 5 years and 10 years and 15 years. Like in our diabetic trials, the studies are done over 10 years, over 50 years, the UKPDS and even the early diabetic study. You have so many trials which go on, because based on those trials, we give our treatment protocols for diabetic eye disease, proliferative retinopathy. I'm talking about my subject because, like you all know, that's my strength. So that's the reason why all these studies become important, because they are done over a long period of time. But the disadvantage is, again, attrition. Subjects will be lost due to many reasons. Okay, that's when the study becomes a bit, what do you say? The results become a bit doubtful. So that's why many studies get cancelled. Okay, so coming back to the subject again. So remember, if the incidence of the disease after studying or after regularly following up both the cohorts for a significant period, then the incidence of the disease is studied. Now, if the incidence of the disease is significantly higher in the exposure cohort, that means there is a positive association between the risk factor and the disease. So that's the reason why for cohort study, it is the relative risk that is calculated. So remember, from exam point of view, odds ratios for case control, relative risk is for cohort. And the interpretation of relative risk and the formula, again, I have discussed that. You need multiple revisions, okay? You need to keep studying them. Now, this is something which I would recommend all my students to remember, and it has helped the previous batches. They have done quite well. I can tell you one of my student has got 156 out of 180, which is a very good score in plab. Okay, just the one which happened in February. There was one exam, right? So all the students who have taken it have cleared plab 1. So remember, it is not impossible. You all can do it too. Just you need the positive mindset. Okay. So this is something which I want you all to, I would recommend you all to remember. So remember, for a case control study, like I said, it is always retrospective. Okay. So in case control, like we all know, you first go from cases and controls. That is, the patient who has the disease is the case, and the patient who doesn't have the disease free is the control. And then you go back and see whether a particular exposure in question has actually, you go back and check the prevalence of the disease you go back and see whether the prevalence of the exposure or the significance of the exposure in the diseased group and the non-diseased group. And then based on the odds ratio, you calculate or you try to interpret whether the association is significant or whether the association has resulted in the disease or the association was protective or whether there was no association at all. Remember, this interpretation is made based on the odds ratio value. Clear?
Yes, ma'am.
Okay. Now coming to cohort. Now cohort, it could be retrospective or prospective. Okay. So answering the question with respect to a cohort becomes tricky. Now, remember, a you're exposing it to either a risk factor or a treatment, and the other group is the control group receiving placebo or no exposure. And then you're following up the group over a particular period of time, and then you're determining the disease incidence in each of them and seeing whether, and depending upon the disease incidence, you try to calculate the relative risk, and then you interpret the association based on the relative risk value. So this is easy. You're going into the future. Now the tricky part is a retrospective cohort. So what is happening in a retrospective cohort? So in a retrospective cohort, again, you know that there is a particular disease in question. Okay. So in this, what's happening is both the exposure has occurred and even the disease has also occurred. So you're going to look into patient records, basically. So first you start to categorize, you try to divide the sample into two cohorts, depending upon whether they were exposed to a particular risk factor or treatment, or whether they were not exposed. And then based on the records, again, you will see whether they have developed the disease or not. Okay, and depending upon that, you calculate the relative risk, and then you try to interpret whether there's an association or not. So remember, though the what do you say, the investigator, though the investigator is again studying the relationship between the exposure and the disease, in a retrospective cohort, both have already occurred. The disease has also occurred. So they are looking basically into patient records. But in a prospective cohort, only there is exposure that is occurring, but disease has not occurred. You're going to go into the future and then study the disease. Is that clear?
Ma'am, could you just
explain again?
Shall I
repeat
repeat it again? Okay.
Yes.
See,
Yes,
in
ma'am.
a prospective cohort and in a retrospective cohort, to summarize, you have to study the association between a particular risk factor and the disease.
Okay.
Okay. So in a prospective cohort, what's happening is you're exposing both the cohorts or both the groups. You're exposing one of the group to the risk factor or the treatment, and you're not exposing the control group. Okay, so you have an exposure group and the control group. So what the investigator is doing is the investigator is going to follow them up for a period of time to study the disease. So when the classification is happening between the exposure and the non-exposure or the control cohort, the disease hasn't occurred.
Okay.
The investigator has to follow up the groups for a particular period and then see whether the disease is going to occur. So the disease has no, where's my marker here? Okay, the disease has not occurred yet. Investigator has to follow up the patient group. I mean, both the groups to see whether to see the incidence of disease in each of them and then do the comparison. But for a retrospective cohort, though the classification is made based on exposure and control, the disease has already occurred. Okay, the disease status is already determined. But you just need to compare the prevalence or the incidence, or you need to determine the incidence in each group and then compare them. That is, do the relative risk. So that's the reason why, like I said, you'll have to look into patient records. First, look at the exposure and then see the disease incidence in them. So it is only based on records. There is no follow-up that is needed for a retrospective cohort, but a prospective cohort needs a follow-up because the disease has not occurred yet. Clear? Is it clear now?
Yes, ma'am.
Okay, so remember, again, I'll repeat myself in another way now. So with respect to retrospective studies, that is going back and digging patient records, you have case control and cohort study. So these are the two important retrospective studies. Now, in the question, when they tell you that of course, it is, you come to know from the question tag that the study is a retrospective one. That is, the investigator is going back. Okay. But if they mention that the investigator is dividing the groups into a diseased and a non-diseased group and then checking for exposure, then it becomes a case control. But again, if they mention that the investigator is categorizing the groups based on exposure to a particular risk factor or treatment regimen and then seeing the benefit with respect to a particular disease, that is, the disease is in question, the exposure is known but disease is in question, then it becomes a cohort study. Okay, if the patient, if the investigator is going into the future, that is, has to follow up patients Okay, follow up the groups if they mention over a particular period, then it is a prospective. You only have one prospective study, and that is prospective cohort. So remember, when answering such questions, you first try to see whether it is a retrospective study or a prospective study. Okay, because if it is a prospective study, it becomes very clear that it is a cohort. But if it is a retrospective study, try to see whether the exposure is known or whether the disease is known. That is whether the examiner is looking at the disease first or whether the examiner is looking at the exposure first. If the examiner is looking at the exposure first, then it becomes very clear that he wants to study about the disease incidence in the exposed and non-exposed groups. That's when case control becomes the answer. Now, that's when cohort becomes the answer. Let me rephrase this again. Now, if it's a retrospective study and the investigator is going back into the records, so you need to see whether the investigator is looking at the disease first or whether the investigator is looking at the exposure first. Now, if the investigator is looking at the exposure first, that is exposure to a risk factor or a treatment thing and its relationship with a disease, then we all know it is a retrospective cohort. So remember, in a retrospective cohort, the investigator is studying the disease. On the other hand, if the investigator is looking at the disease first, trying to divide the groups into cases and controls, and then going into the exposure, then we know the investigator is interested in studying the exposure. So that's when it becomes a case control. Is it clear? Any doubts? You want me to repeat anything?
In prospective cohort, there is exposure. I mean, like when comparing with the retrospective cohort, like you said, it's whether the exposure or the disease that the investigator is going behind. So in prospective also, there is the investigator is going behind the exposure.
But in prospective, the disease has not occurred yet.
Okay.
The investigator has to follow up the groups and then determine the incidence of the disease. But in a retrospective cohort, the disease has also occurred. So that's why he has to dig into the records and check. But he will start off first from the exposure and then look at the disease.
Okay.
Okay. Anybody else? Any doubts? So should I consider that as no doubts from anyone else? Okay, the famous silence. Okay, now cross-sectional study is actually a simple one. Now in cross-sectional study, you're basically taking a cross-section or a small sample of the whole population so that the results can be generalized. So this is used basically to compare diagnostic tests. It's also called a snapshot study because you're basically taking a snapshot, which is nothing but a small portion of the entire population, and you're studying it at that particular period of time, at that particular point of time. Okay, that's the only thing they'll ask. They won't ask you any calculation. Nothing is important here. And remember, it is with respect to a disease prevalence. Okay, these are the only 2 points you need to know. Then what is systematic review? Systematic review, remember, it focuses on a clinical topic and answers a specific question with respect to the topic. And what is meta-analysis? Now, meta-analysis, again, is a number of studies on a particular topic, and it combines the results of, all the results, the results of all the studies Okay, and ultimately gives an end result. So what you need to remember from our exam point of view is that, remember, meta-analysis is nothing but a compilation of a number of studies on a single topic. Okay. Now, the experimental study, again, this is a very important one, which is a randomized controlled trial or a clinical trial. In the question, if they say anything with respect to a drug trial being considered, then they're asking you about an RCT, about a RCT. Okay, so remember, a drug trial, if drug trial is mentioned in your question, straight away mark RCT. So in RCT, what happens is the cases of the disease are identified. And after the cases of the disease, or after the cases are identified, an informed consent is taken. Then they are randomly allotted into a study group and a control group. So the study group is generally given a particular treatment or a vaccine or a drug. And the control group does not receive the treatment or the drug. So after this exposure, they are followed up. Then after being followed up for a particular period, again, the disease incidence or the cure rate is determined. That is, the number of patients who are disease-free in each group is studied and compared. Okay, if the difference between the two groups is quite significant, that means the therapy or the vaccine is a better curative option. Okay, so remember the difference between the two groups with respect to the disease-free individuals should be high or significant. So like I said, if drug trial is mentioned, mark RCT. Another important thing which they ask you is, how do you minimize, how is bias minimized in an RCT? Remember, it is by blinding. So you have three types of blinding: single, double, and triple. Now single is, remember, in single blinding, the patient is unaware. In double blinding, the patient and doctor both are unaware. And in triple blinding, the patient, doctor, and statistician, all the three are unaware. Is it clear? Any doubts? Okay. Now, and one of the important disadvantage, like what by blinding. So what is bias? You have a selection bias. Now selection, it occurs whenever the selection of the groups occurs based on certain factors. Then what is measurement bias? Measurement bias is whenever the measurements are imprecise. Okay, or the methods or different methods are used for measuring the same thing between the two groups. So that is nothing but measurement bias. So remember, either the values are imprecise or the methods used are not similar. Then what is confounding bias? Now, confounding bias is when two factors are associated and the effect of one is confused or distorted by another. So that is confounding bias. For example, you're studying you're studying the effect of a particular drug which is used in hypertension. But you come to know that the patient also has hypercholesterolemia and is also a diabetic, and even that could affect the outcome of the drug action. Okay, so those are the confounding factors, the hypercholesterolemia and the diabetic nature. Okay, and the diabetic condition. So those will be the confounding factors in the example I just gave. So remember, when there are two or more factors, the factors are associated with each other, but they can also cause some confusion or distortion with respect to the end result. Then you have ecological bias. Ecological bias is also called aggregation bias or fallacy bias. Now, an association is observed between variables, that are representing group averages, and this is mistakenly taken to represent the actual association. So remember, it is actually a relative association, but it is assumed to be an actual one. Then reader bias is basically errors of interpretation. Then you have something called zero time bias. Now, zero time bias, what happens is individuals are found and enrolled in the same fashion so that the systematic differences can be avoided in the beginning. But what happens is as the study progresses, these these unintended systematic differences, they become obvious. Okay, they with respect to definition, definitely you need to know selection bias, measurement bias, confounding bias. The other three I've just added because even they could be asked. So you just need to know the definition of each. Okay. Now again, the techniques to control bias, the most important one is blinding. Also, randomization will help in controlling bias. And you should also know allotment concealment. So these are the three different ways in which bias can be avoided. Okay. Now, again, this is the same table format of what I've just discussed. You should know what is a chance event. Now, what is a chance event? It is nothing but a specific cause that cannot explain why a patient has dropped out. That is the dropout or the attrition has occurred by chance. We all know attrition is a common problem for a long-term study. And attrition is commonly seen in prospective studies. So it is seen in cohort, as well as it can also be seen in RCT, because again, that's a prospective study where you need to study over a long period of time. So attrition is nothing but whenever there is a decrease in the number of subjects in a particular group, it could either be case or control. Now, generally attrition, there will be a certain reason why the patient drops out from the study. So it could either be due to personal issues or family issues or health issues or death. So those are the different causes. But whenever this dropout occurs by chance, that is, the cause cannot be determined for the dropout or the loss of a particular subject, that's when it is called a chance event. Is that point clear?
Yes, ma'am.
Okay. Another important failure with respect to a study, apart from attrition and bias, would be breakdown. And what is breakdown? So remember, breakdown, a breakdown is said to occur if people from either group know that they belong to the respective group. Like we know in a blinded study, especially in a double and a triple blinded study, the patient or the subject, the doctor and the statistician are generally unaware of each other. So actually the subject doesn't know whether the subject is in the trial group or the case group or the control group. But once the subject becomes aware of this, that is the subject is in the experimental group or in the control group, that's when there is breakdown of the study. And this is another common cause for failure of a clinical trial. Another important point.
Breakdown is like actual like the literal breakdown.
No. Because we all think breakdown means attrition, right? There's loss of subjects. That's what we think. But breakdown in statistics doesn't mean attrition, but it means that the subjects are aware of which group they are going to. And once this happens, the study is a failure. So that's why it's called a breakdown.
Okay.
Okay. Now, with respect to attrition, one second. Now, with respect to attrition or dropout, you should know that it becomes significant when it's more than 15%. That is when the dropouts or the loss of population, the loss of subjects is more than 15%, it is significant. It is acceptable up to 15%. Okay, this is another point which you should remember. Okay. Now, let's talk about distribution. So with respect to distribution, you need to remember what is mean, what is variance, what is standard deviation, and what is a continuous distribution. Now, what is mean? Mean is the average value of a of all the values. You take the mathematical mean, which is nothing but the average value. Then what is median? Median is basically in median, what you do is you arrange all the values either in ascending value, in either in ascending order or descending order, and then you take the value which is in the middle or which is halfway. So it is nothing but the halfway value. Then what is mode? Mode is nothing but the value which is more frequently repeated or which frequently repeats. So it is the repetitive value. So mean is arithmetic mean, median is halfway value, and mode is the repetitive value. Okay, those are simple. I'm quite sure you all must be knowing. Now, what is variance? Now, variance basically helps to represent how spread out the data is. Okay, that is how diverse the data is. Now, remember, always variance is measured in terms of standard deviation. So what is standard deviation? It is the square root of, it is a square root of variance. Then for continuous distribution, remember continuous distribution, generally it is expressed as a continuous function or a graph. And generally it is a smooth curve for a continuous distribution. And the most common that's the commonest distribution, which is a bell-shaped curve. Now, and other examples for continuous distribution could be a chi-square distribution, exponential, then logistic, and student state distribution. All these are some examples for continuous distribution where you're going to get a smooth curve. But for our exam, you need to know some details about normal distribution. So remember, normal distribution is a bell-shaped curve. And with respect to this percentages of value, I just have, percentage of values, I have another picture wherein I'll talk about 68, 97.5, 99. Okay, I'll talk about that in that picture. So though chi-square distribution is a continuous distribution, but remember it is asymmetric and skewed to the right. Okay, that's an important point. So asymmetric and skewed to the right is a chi-square distribution. But on the other hand, normal distribution, there is no skewing. It is a symmetric distribution, symmetric and continuous. So what is a chi-square distribution used for? So remember, it is used to compare the observed values to the expected values and also to rule out if the observed values are due to chance. Again, this definition has been asked, so please memorize that. Then also, whenever you need to examine a small sample of data, then you use the student's t distribution. So remember, even student's t distribution, it is a normal, it has the features of a normal distribution, but it is over a small sample. Clear?
Yes, ma'am.
Okay. How many slides do I have? Okay, can I do this on Thursday? Today I actually had a power breakdown in my house and I had to fix that. Hopefully Thursday I should not have anything. I will do this along with the bouncer class too on Thursday. Okay, the bouncer class two, I mean, the bouncer two topics are quite simple. It's basically genetics and random stuff like that. This bouncer one only, which is tricky because of biostatistics. So I'll just continue this on Thursday. Okay.
Okay. Okay, ma'am.
So happy revising until then. And the next week I'll put up all the 3 grand mocks along with the keys. So you guys can solve it whenever feasible. Okay. So just remind me that we have to start off with slide 20. So see you guys on Thursday, which will be the last class for this batch. Take care then.
Thank you.
Thank you, ma'am.
Bye. Bye.